Welcome everyone to TEPI's Infection Prevention 202 module, Occupational Epidemiology and Prevention. This module briefly introduces occupational epidemiology and the OSHA bloodborne pathogen exposure plan. Feel free to post any questions in the Q&A throughout the presentation. A knowledge check activity will be at the end of this lecture to gauge your learning from the material that we talk about. At the conclusion of the webinar, you will receive a link to a post-survey evaluation of today's material that we would really appreciate if you could complete. Within a week, you will receive an additional email with a copy of today's slide deck from the presentation, along with a recording of today's presentation. Before we begin this module, I would like to briefly introduce who and what TEPI is. The Texas Epidemic Public Health Institution, known as TEPI, is a state organization headquartered at UT Houston School of Public Health to keep Texans safe and the Texas economy strong by preparing for the next infectious disease outbreak. If you would like to learn more about TEPI, we have a few QR codes at the end of this module that can guide you to different resources. My name is Kayla Rush, and I will be today's presenter. I am an infection prevention practitioner who is certified in public health, healthcare accreditation, and infection prevention and control. During the pandemic, I had the opportunity to work at acute care hospitals here in Texas, a long-term and skilled nursing facility in New York City, and then returned back to acute care hospitals in California before returning to UT Health to pursue my PhD in epidemiology with a concentration in infection prevention and control. The learning objectives for this module are to introduce occupational epidemiology concepts and explain how they play a role in infection prevention. And I am also going to describe and explain the OSHA bloodborne pathogen exposure plan. As I mentioned, this is just a brief overview of some of today's components and their roles in infection prevention and control practices. So what is occupational epidemiology? Occupational epidemiology is the science of epidemiology that's focused on the occupational environment. This includes the assessment of health risks for occupational exposures, investigation of disease outbreaks, and research to establish the scientific basis for regulation and control of chemical, physical, and biological agents with psychosocial and ergonomic health hazards in the workplace. This specific concentration of epidemiology focuses on worker safety. For infection prevention and control professionals, it focuses on creating a safe work environment for all healthcare workers by developing and implementing policies and procedures such as the OSHA bloodborne pathogen exposure plan, a respiratory program, and other prevention practices in the occupational settings. The goal is to ensure that workers have a safe and healthy workplace, free of hazards, so that they can return home from work to their families without injury and illnesses at the end of each day. We will discuss these themes through today's presentation. Before we begin this section, we want to briefly talk about some of the terminology we'll be using today. In terms of infection prevention and control, we consider occupational exposure, defined as contact with blood or other potentially infectious material that will result from contact with skin, eye, mucosal membrane, or perinatal exposures. We will be using these definitions in today's modules when we're talking about exposures and specific bloodborne pathogens. And a few other things that we want to discuss are immunoglobulins, which are the antibodies that are produced within our plasma. This is what helps us create protection from certain pathogens. Hepatitis B immunoglobulins are a form of a type of immunoglobulin specifically developed to be given in a post-exposure event when you are exposed to someone with hepatitis B. And then next we have post-exposure prophylaxis, which is the introduction of ART or antiviral treatment. And these are usually given after an exposure event to someone that is known HIV positive to help prevent seroconversion. And then lastly, we're going to discuss the differences between immunization and vaccination. Immunization is the process which a person becomes protected against a disease through vaccination. It requires an immune response to be developed when given the vaccination. And this immune response requires the body to produce antibodies to a specific pathogen for protection. Compared to vaccination is the act of introducing a vaccine into the body to produce immunity to a specific disease. So just because you have been vaccinated does not necessarily mean you have been immunized for that specific pathogen. And usually in occupational health settings, we do this by doing confirmation tests, such as drawing titers on you to measure the type of antibodies for a specific pathogen that you might have received a vaccine. And a great example of this is when you start into a healthcare environment, they might ask you for your record of your hepatitis B vaccination series. Once you provide that record of saying, yes, I did receive the vaccination series, then the occupational health worker might set an order to have blood titers drawn to measure your immunity, as in your antibody level to the hepatitis B vaccination series. So then they'll draw your blood, look at the specific antibodies, and if they are present, then they can confirm, yes, you have immunity to hepatitis B. So that kind of shows the difference between vaccination and immunization and the two different steps that can be used in occupational health when talking about these things. Next, infection prevention policies, procedures, and practices in occupational health settings are designed to interrupt the transmission of infection between healthcare workers and patients and prevent injuries by having safe practices in place. The Centers for Disease Control and Prevention, known as the CDC, uses the term as healthcare personnel as all paid and unpaid persons in the healthcare settings who have the potential for exposure to infectious material, which includes bodily substances such as blood, tissue, specific bodily fluids, contaminated medical supplies, devices, equipment, contaminated environmental surfaces, or contaminated air. Personnel may include, but are not limited to, your emergency medical services personnel, dental services, laboratory, autopsy, nursing, providers, physicians, technicians, your therapists, your laboratory workers, pharmacists, students, interns, volunteers, clergy, clerical, maintenance, and your contractual individuals that are not necessarily employed directly under the organization. So long and short, a healthcare personnel is anyone within the healthcare setting, paid or unpaid or volunteering. And this is something to be very specific and important to that it's everyone's responsibility who's at risk that these rules and programs should be developed towards. So some of the infectious processes that are present and pose a threat to these individuals might be prevented by administering pre-exposure immunization. And we just briefly talked about one of those with the hepatitis B series vaccination. That might be given or asked on employment when you're in a healthcare setting that you might be exposed to potential blood-borne pathogens that, hey, this is a vaccine that is recommended for you for prevention. And if you do not receive it, they might send an order and offer it to you as well. Other infectious diseases processes can be caused by communicable diseases that have specific indications for post-exposure interventions. And these are a lot of our treatments, and specifically when we talk about HIV exposures, that there is no primary prevention for them, such as vaccination, but there's post-exposure prophylactic that we can give individuals. And we'll talk more about this in details in some of the later slides. Yet even with these measures of prevention and post-exposure intervention, we can still have exposures. Therefore, we need to involve our measures of prevention strategies to reduce the risk. And as we've discussed in previous lectures, primary prevention occurs when pathological onset of the disease occurs and is aimed at reducing the incidence of disease. And primary prevention is a lot with our vaccinations that we can get to prevent before we're exposure. Another level of primary prevention is our policies and procedures that we put in place to help us reduce the risk and make sure that we are in a safe environment while we're working. Secondary prevention is developing screening programs for asymptomatic individuals, even though that they potentially have been exposed, they are not showing symptoms at this time. So a good example of that is developing TB screening for areas that are endemic to tuberculosis. So a lot of times based on your incidence of tuberculosis in the community, they will conduct annual screening testing to ensure that even though that you present asymptomatically, you're not incubating the pathogen, and so that that level of protection is there. And then thirdly, there is tertiary protection, which is slowing or stopping the disease progression. And a good example of this would be administering ART treatment for your prophylactic exposure in the chances that you have been exposed to HIV in a specific setting. The healthcare organization, administration, medical staff, and other departments should support these elements of infection prevention and occupational health personnel. The occupational health infection prevention's goals should include the education of healthcare workers about primary principles on infection prevention and their responsibility for infection prevention measures, along with collaboration with the infection prevention department in monitoring and investigating potential harmful infectious disease exposures and outbreak, along with having provisions of care and follow-up to healthcare workers that are involved in work-related illnesses, injuries, and exposures that occur. We also like to partner with and identify work-related infection risk and institute appropriate prevention measures while trying to maintain costs by preventing infectious diseases that result in employee absenteeism and disability. The elements that should be included when designing an occupational health service or department for healthcare workers is the collaboration and oversight of department by a licensed healthcare provider who is responsible for the medical records and orders for pre-exposure vaccination, medical health screenings, and post-exposure treatment. Coordination with other departments that support the infection prevention objectives can ensure surveillance for infection and personnel, along with this assessing for exposure investigations and implementation to prevent of prevention measures. Medical evaluations should be performed before job placement to ensure that the personnel that is now working in this environment does not pose an infection risk to the individuals or patients that they are working to. By conducting these medical evaluations, it's great to obtain more information and kind of know what the risk is for the environment that the individual is going into, and then also the risk that that environment poses to that individual. And based on this information obtained during these medical evaluations, job duties and responsible placement might need to be reconsidered depending on this infection risk. So it's really important that we conduct these medical screenings to ensure that it is safe for this person to work in that environment, that they're not exposing that environment to something that it can't overcome, and vice versa. The environment is not too harsh for this individual, therefore making them sick. So it works in both directions. And by understanding this rationale, along with obtaining and understanding federal, state, and local regulations, personal health and safety education can contribute to worker compliance of infection prevention practices, thus creating a safe working environment for all healthcare workers and our patients. OSHA requires employers to provide a respiratory protection program for healthcare workers working in the environment that could require a respirator. In the healthcare setting, respirator protection is necessary when caring for patients with suspected or confirmed TB or other airborne pathogens. The generally accepted respiratory protection that's used for this type is for suspected or confirmed TB along with other pathogens is usually your N95 respirator or your powered air purifier respirator known as your PAPR. Those are the most two commonly regulatory respirators that are seen in healthcare settings, but based on your facility and your infection risk analysis, you might be able to use others as well. During the pandemic, we saw a lot of variation based on our resources that were available, and therefore OSHA and CDC did come out with other laws kind of saying due to the pandemic that different level of respirators could be used based on the need due to the not being able to have the proper PPE. So be aware that this is the general rule that we use in N95 or PAPR, but depending on the situation, if it's a pandemic or a disaster response, there might be other respirators that might be used based on your availability and your resource line. And then while you're having these respirators, there's two ways to test for them. You can either test for them qualitatively or a quantitative fit test assessment to determine what mask size will fit your specific face. So this is not a one size fits all. With your N95, there are different sizes. Therefore, you need to have a fit test performed to ensure you are wearing the right size. And also, each brand of N95 fits differently. So if your facility changes brands, you will need to get refit tests to ensure that you have the proper seal. It is also recommended if you go through any type of facial change of losing weight, or you break your nose, or jaw reconfiguration, any big change after that time, you'll need to get refit tested again to ensure that you have proper seal. And the importance with the fit testing is that we're testing the seal. And when we test the seal, we can either do it in a qualitative or a quantitative way. As I mentioned, the qualitative way results in a pass or fail with the ability to detect a smell or a taste, depending on what your facility is using. So at that time, they'll be able to tell you, hey, do you taste or smell anything differently? And that will tell you if the seal is appropriate or not. Compared to you can have a quantitative fit test performed, and that assessment uses a machine that measures the actual amount of leakage during when you have the respiratory put on your face. This test doesn't rely on a person's sense of taste or smell. Compared to the qualitative, that individual definitely needs to be able to report those types of things. So if you have an individual that has lost their sense of smell, doing a qualitative fit test will not yield a good result. So be mindful of that too. And then also, if you are conducting your fit test, making sure that you're asking your healthcare workers, do you have any issues with sense of smell? So you might need to then fit test them differently based on their answers. The quantitative fit test uses a machine that hooks up to it that measures the amount of leakage, which is sometimes a little bit better than just having a qualitative answer of can you smell it, can you not? And then OSHA requires employees to establish and implement a written respiratory protection program with worksite specific procedures. The respiratory program includes effectiveness and should be reviewed annually and updated as necessary. Program elements include procedures for selecting respiratories used in the workplace, i.e., what and how you selected this model, medical evaluations for personnel required to use the respirators, that would be your fit test, conducting fit tests, and procedures for proper use, storing, and discarding of respirators. So that's going to make sure that there are training and you are laying out in your policy that you need to show them how to put it on, take it off, store it, maintain it, and you must be fit testing and they're wearing the proper size that they've been fit tested with. Another plan element should address training. So this looks at specific training that involves safely donning, putting on, and doffing, removing the respirator to ensure that correct placement is and that they are not cross-contaminating themselves or others when taking off a contaminated respirator. And for a review on donning and doffing, you can refer back to the IPC Module 101. The proper remover helps decrease risk of cross-contamination, as I mentioned. And then lastly, maintenance involves reviewing your respiratory protection plans and policies and conducting pandemic and disaster preparedness protocols and drills. So now that we've talked about some components and described some occupational epidemiology and health practices, we're going to discuss the OSHA bloodborne pathogen exposure plan. First, what are bloodborne pathogens? I've kind of mentioned a few of them, but the specific definition that we work with are that they're microorganisms that are present in human blood or bodily fluid and that can cause disease. Some pathogens have treatment that can be provided after exposure. However, not all pathogens have specific treatment. Exposure to bloodborne pathogens pose a serious risk to healthcare personnel, especially the pathogens that do not have post-exposure treatment that we can give them. So avoiding these occupational exposure through adherence to standard precautions and safe work practices, such as developing an institutional culture of safety, establishing policy and procedures, educating staff on pathogens, and having administration support is essentially to reducing risk. Using proper barriers to prevent blood and bodily fluid contact, along with preventing percutaneous injuries by eliminating unnecessarily needle uses, implementing safety features, using safe work practices when handling needles and other sharp devices, along with safely disposing of sharps and contaminated material really helps reduce the risk. And these are known things that we can do to prevent exposures. However, even with our policies, procedures, and training, we still have exposures. So what do we do when we have them? So just a few common examples of some pathogens that we commonly see in healthcare settings are hepatitis B, hepatitis C, HIV, T. pallidum, which is known as syphilis, which we are seeing a huge increase in Texas and specifically in the Houston area, and TB. Some lesser common but really important pathogens to be aware of that are highly contagious and have a high incidence mortality rate, along with do not have prophylactic treatment, is a lot of our viral hemorrhagic fevers, such as Ebola and others. So it's really important to be aware of what prevention measures there are, along with what type of infectivity that some of these pathogens have. So all these pathogens on the list, and you can see some of the beautiful pictures, can be transmitted through blood and other bodily fluids during exposures. Bloodborne pathogen exposures can come from multiple sources and routes. Using standard precautions and being aware of potential hazards are essential. Potential sources of exposure are usually blood, semen, vaginal secretions, saliva, synovial fluid, cerebral spinal fluid, and other bodily fluids such as blood, urine, feces, and vomit. Most of the time, we think of urine as being very sterile, so just be mindful that it can harbor pathogens. So just when you're obtaining urine cups, you need to be wearing gloves when handling those things, along with blood tubes as well. So just be aware of those things, that all these substances can harbor pathogens, and as a prevention measure, you always want to use standard precautions when handling these things. Possible routes of exposure include our percutaneous inoculations, which involves a lot of our needle sticks, our misuse of sharps, contact with our mucosal membrane, such as splashes to our eyes, nose, and mouth, and exposure to our broken or damaged skin. These exposures are due usually with coming into contact with broken glass, needles, scalpels, splashes, as I mentioned, to a main one. The infection exposure risk increases with the length of time of exposure and also due to the area. So if you have a larger area of unbroken skin or broken skin and it has contact with one of these bodily fluids, it increases your risk of developing an infection based on a bloodborne pathogen. So not only have it been proven to show that having bloodborne pathogen exposure plans really help keep workers safe, it's also a regulatory requirement. OSHA published the final bloodborne pathogen standard in 1991 in response to the significant health risk associated with occupational exposures to blood and other potential infectious material. At the time, nearly 6 million workers in healthcare and occupational settings were faced with bloodborne diseases. 6 million back in 1991. Since the standard was implemented, the rate of occupational hepatitis B infections has dramatically declined. The standard was then revised 10 years later in 2001 to include safer medical devices such as sharps that have engineering tips for protections and needleless systems. The Texas standard that we have in our state is analogous to the OSHA standard. Texas does not have a state OSHA, therefore the federal OSHA applies to the private work sector within our state. However, federal OSHA does not cover state and local workers, but at this level, then that specific entity and body should be using state legislation along with the federal OSHA plan, a bloodborne pathogen, to use as a footprint and a gold standard to develop their own plan that meets our own state specific regulatory requirements, specifically in that healthcare setting. There are 10 main components that go into the bloodborne pathogen plan, and we'll briefly discuss each of them. The first component of the exposure plan is the policy development. The policy will lay down the foundations to your exposure plan. It will include steps in your regulations. The policy will be reviewed and staff trained too. So the important thing is to develop your policies. These are your rules and regulations for specific your facility, your patients that you see, and your healthcare workers in your setting. The policy will state the department and the persons who is responsible for the facility's exposure control plan, which includes who is responsible for implementing the exposure plan, who will maintain it, review it, and update the plan along with their contact information to this individual. So this plan will pull out all your steps and then also designate a specific individual with contact information of who is in charge of this. So then in your facility, if there is a bloodborne pathogen exposure event that occurs, your staff can go to the plan, look at the policy, and know who is in charge that they need to call to make the determination. And this will lead into specifically what the program administration for the bloodborne pathogen plan does. The plan will list what records will also be obtained along with what specific timeline and regulations from OSHA need to be followed. The program administrator will make the determination if the employee exposure has occurred. So not only is there a plan in place with rules and steps, it designates a specific individual that will then conduct this exposure assessment. This exposure assessment is not to be performed by anyone and everyone in the facility, but at one designated person, and that really helps keep it uniform of doing every exposure assessment in the same way, and that we are collecting all the necessary information. The method of exposure control implementation will consist of reviewing universal precautions, analyzing engineering and workplace controls, evaluating personal protection equipment, housekeeping procedures of cleaning, hepatitis B vaccination history, post-exposure evaluation with follow-up, along with communication of hazards to employees, reviewing employee training, keeping records of the event, and the procedures for evaluating the circumstance of the exposure incident. The next component of the employee exposure is the determination and method of implementation and control. The program administrator will determine the employee exposure event. This involves listing the employee's name, job title, and department of where the location of the exposure risk occurred, along with what events occurred during this, i.e., who, where, and when did this happen and what was going on. This information will then be used to understand what occurred and therefore be able to determine what methods of implementation and control need to be put in place. This involves looking at universal precautions, i.e., how to stay safe in exposure events, reviewing exposure plans, and looking at what engineering control and practices were in place, along with what PPE was worn, and their current hazard disposal practices, along with labeling practices at the time of incidents. The next section of bloodborne pathogens just one second. Sorry for that. The next section of bloodborne pathogens involves evaluating vaccination status. Does the facility require vaccination for any pathogen? This is usually seen just with our hepatitis B series. If there is another type of exposure with a different pathogen, if it's bacterial, maybe a needle stick with someone that is confirmed influenza A positive, they might look at if you've gotten your seasonal flu shot. But usually the standard procedure for the vaccine that they're most looking at is hepatitis. And most healthcare facilities will require individuals to be vaccinated for hepatitis as a preventive measure, or during the post-exposure event and follow-up, they might recommend a hepatitis B vaccination if the individual has not previously been vaccinated, or provide Hep B immunoglobulins as a preventive measure for having to delay the seroconversion. During the post-exposure evaluation and follow-up period, the routes of exposure and how the exposure occurred will be identified and documented. Consent from the source and exposed individual will be obtained prior to laboratory results being collected. So during an exposure event, i.e., if someone gets stuck with a dirty needle, you have your source person, as in who used that device, that needle, that sharp device that had that pathogen, that's your source person, and then your exposed individual is who got either that sharp or anything. So at this time, there's two people involved. Consent for laboratory testing needs to be obtained by both before any labs are drawn. And then after consent has been obtained, it should be prioritized to have the source individual test as soon as possible to determine their HIV, Hep C, or HIV virus infectivity. The source individual's test will then be provided to the employee health provider and documented in the exposure plan. If the source individual is already known to be HIV, hepatitis C, or B positive, new testing may not need to be required since they are a known positive. However, this is dependent on your specific plan and procedure. The exposed individual will then be provided with the source individual's testing result and information regarding disclosure laws and regulations concerning the identity infectious status of the source individual, as in laws that protecting confidentiality, such as your HIPAA regulations. So the source test results will be made known to the healthcare person that has been exposed, and then also to the employee health individual that is in your exposure plan that has been designated to run your plan as well, so that they know what the test results are so they can treat accordingly. Collection then of the exposed individual's blood should be performed as soon as possible after the exposure incident has been done and test for hepatitis B and hepatitis C serology statuses if the employee does not give consent for HIV testing. So at this point, there can be an exposure event, and even though the person has been exposed to a pathogen, they can still decline testing. That is their right and their choice. And if that is done, it needs to be documented as well. Just like it needs to be documented if testing has been obtained. If they choose to be tested for Hep B, but not HIV, you want to bank that tissue, that blood sample, possibly for later testing if they decide to change their mind. And that's usually banked for about 90 days or more. So even if they declined, you want to keep some blood in case that later they decide, hey, I would like to be HIV tested. And lastly, the administration of post-exposure evaluation and follow-up is the responsibility of the individual listed. This individual will evaluate the employee after the exposure incident and ensure they obtain following information such as their description of their employee's jobs relevant to the exposure incidents, routes of the exposure, circumstances that were related to the exposure, and if possible, the source, individual's blood tests, relevant medical records such as vaccination history. The individual then provide the necessary treatment and ordering of tests, medication, and conduct following appointments and follow-up procedures to the exposed event. So after blood has been taken, we test it based on their testing, then medication and follow-up appointments may be needed based on their testing result or what the patient, the exposed individual determines as well. Medication can be offered to them. However, they still have the right to decline it as well. That's completely fine. However, that needs to heavily be documented. Just like in anything in healthcare, we need to make sure that we are documenting, especially when we have an exposure event, if they do have to, do agree to treatment, if they don't agree to treatment, etc. The employee will then receive a copy of their evaluation for their personal records, and a copy will be placed in the occupational health appointment flyers. So 2 copies of records to the individual and to their occupational health file as well. For procedures for evaluating the circumstances surrounding exposure incidents are done by conducting an investigation, which usually looks at the root cause analysis or gap analysis and practices to determine what implementations can occur to prevent this incident from reoccurring. So after we have tested our employee, provided them treatment, conducted follow-up appointments, at that time then we are doing a deep dive of what happened and why, and what can we do to prevent this from happening again. So that's all part of your incidents exposure event. Analysis of the following can be really helpful, looking at circumstances around the exposure incidents, engineering controls in use at the time of event, workplace safety practices that were followed during the incidents, and also identifying the ones that were not followed during the incident. So both looking at what was done well and what was not done well. A description of the device being used, including type and brand, because this can also lead us to great information. If this was a device specific, so then maybe we can remove this device and go with a different product instead that's safer. Also, where the exposure occurred, was this in a specific unit? What PPE was worn during this time, along with what procedure was being performed of the incident and the employee's training. If opportunities for process improvement are discovered during this analysis, the improvements should be immediately implemented to ensure safer practices. The next thing you want to look at is the employee training should be reviewed, and based on those findings of the incidents, maybe new or retraining needs to be conducted. If that is a finding, a training plan needs to be developed and documented, which includes who is the person responsible for the training and what is the training timeline, before that the individual will be deemed fully or retrained and they are competent to do the task individual. A copy of the training plan along with completion dates will then be put in the incidents file as well. And in the employee's file to say that they have been retrained on this to help reduce the risk of another exposure of occurring. And this will serve as your record of event from the incident of looking at what happened, why it happened, was something identified to improve this, was training reinitiated, or was there a failure in PPE or a control measure that we can now put in place. And all of this finding will be your record of event from the incidents. And then lastly, here's a picture of your OSHA sharp injury log template. A copy of this log is at the end of the presentation, which you will have access to within a week. Any bloodborne pathogen exposures, specifically to sharps injuries, need to be logged, and these logs need to be maintained for the history of employment of that individual plus an additional 30 years. So this is the big regulatory requirement if OSHA ever has a site-specific review or during your credentialing process, they might ask for this. So make sure that you are obtaining and retaining your records of events since it is a regulatory component. Other relative information should be documented on the exposure log, which includes the vaccination history of the specific pathogen as well. And that kind of completes your overall OSHA bloodborne pathogen exposure plan of having your policy, who's in charge of it, who your program administrator is, what's the steps of when a bloodborne pathogen exposure occurs, who makes the determination, what data is obtained, and then lastly, our log to document the event. So now let's talk about ways that we can prevent exposures from occurring. It's essential to implement effective infection prevention measures, but before we can implement them, we really need to understand the hierarchy of control. Implementing the hierarchy of controls can help reduce the risk of harm to both staff and patients. The first step and most effective step is to eliminate the hazard by physically removing it. Then it is to substitute the hazard by replacing it for something better. The next one is our engineering controls, which means to isolate the people from the hazard or taking them out. Then it's followed by administration control. That's our policies and procedures in place. And then lastly, the least effective measure is our PPE, which is what personal protective equipment can be worn to help prevent us from being exposure to bloodborne pathogen. For more information on the hierarchy of controls and how you can implement it, you can also refer back to our IPC Module 102. And then another key component is having adequate and appropriate training. All bloodborne training, along with other training, should occur, and also having annual bloodborne pathogen training is a requirement, a regulatory requirement. This can be reviewing the educational module through a policy review and then taking a post-module exam, having a discussion, lunch and learn. It's up to you and your facility, but having annual bloodborne pathogen training is a requirement. It's also recommended that you check all safety requirements and regulations that happen and update through the year so that you're aware of new types of training and regulations so that you are on a regulatory process, that you are being compliant with them. And then also being aware that job and licensure have specific trainings for certain licensures and credentials. So making sure that we have that adequate training for the specific individuals based on their job requirement is directly relates to helping keep our staff and patients safe in healthcare settings. And then another critical component is having great safe sharp practices, and following these simple but effective measures can prevent many sharp injuries. The first one is Never recap a used needle. This is an essential thing to prevent injuries. Place sharps directly in biohazard containers, and your biohazard containers should be your leak and puncture resistant containers specifically for sharps. And these should not be overfilled. You should only fill them to the line directly indicated on the box. If you overfill them, it's most likely then the container will not close, therefore increasing your risk of potential exposure. Next, you don't ever want to manipulate a sharp, as in bend it to put it in a container. If it does not fit, go find another container where it adequately fits. And also do not pass sharps between individuals. Do not, if you're using a sharp, do not hand it to another of your staff to go dispose of. You directly walk over to the disposal and put that sharp in. And lastly, if you have a sharp device and you accidentally drop it, do not try to catch it. Let it fall to the floor and discard it. It is now cross-contaminated, but do not try to quickly grab it. That usually leads to punctures and other type of sharp exposure. So doing these essential safe things can really help reduce sharp injuries in the healthcare settings. And then lastly, we just want to talk about handling and disposal of medical waste. That is very integral in healthcare safety. Proper handling, storage, transportation, and disposal is critical in mitigating risk. Improper waste control can have specific and severe adverse health effects both on the patient, the staff, and the environment. So it's really important that we adhere to good practices. Medical waste is often called infectious or hazardous waste. It involves the contamination of blood, bodily fluid, or other infectious agents. And medical waste is divided into 3 different categories of infectious waste, radioactive waste, and sharps waste. Infectious waste is commonly seen with our PPE, our IV tubing, our bodily tissues, and other specific disease-causing pathogens. Our radioactive waste is frequently seen in specific isotopic materials. And then our sharps waste we just discussed, as well as our needles and syringes. Autoclaving and incineration is the best practice for recommending a disposal, but refer to your specific facility policy and procedure on how that you disinfect medical waste before disposing it. And for more information, you can again look at Module 102 for more details. So we've heard a lot about occupational epidemiology and OSHA bloodborne pathogen exposure plan today. So in summary, occupational epidemiology and occupational health is a combined discipline dedicated to the well-being and the safety of employees. Many occupational health components involve having safe measures in place. However, exposures do occur. And due to exposures occurring, it is a regulatory requirement to have an OSHA bloodborne pathogen exposure plan, which dictates the policy and procedure of when these exposures occur. Having all of these things are necessary to ensure that we keep our healthcare workers safe while they are at work. So for those who cannot stay for the learning activity, we just have a quick announcement before moving into it. Immediately after the lecture, as I said at the beginning of this module, a post-survey evaluation will be emailed to you. You can also have a copy of the QR code here. It will take you to the survey. It takes about a minute or 2 to fill out, and we would greatly appreciate if you could fill this out and provide us with any feedback based on today's material. We really look at it to help us develop the next module and give you more content that you're wanting. Our next module will be on April 4th, titled Surveillance, and we're looking at specifically what is surveillance, how to conduct it, why is it important as well. And for those who complete the post-survey evaluation, you have a chance to enter in your email to win some free Teffy swag. So now it's your turn. We're going to go into our knowledge check, and we really want this part of the lecture to be interactive. So on the screen, you have your QR code. It's a short 10-question learning activity that we'll do together. Feel free to raise your hand during this part of the section, and we will unmute you to discuss the questions in the material. And then after the learning activity, we'll open up for all general questions. So you can just scan the QR code, or the questions are in the slide deck as well, and we'll review the answers at the end. So question number 1. Occupational health focuses on A, occupational exposures, B, investigation of disease outbreaks, C, prevention, or D, all of the above. So what do you all think? Feel free to raise your hand and we can unmute you. No takers?
Hannah?
Hannah, can you hear us?
Yeah.
What do you think the answer is?
Oh, D.
D. That is correct. Thank you. Question 2. What infection prevention policies, procedures, and practices are established to create a safe environment for healthcare workers? A. Specialized training and education. B. Exposure control plans. C. Vaccination requirements. Or D. All the above. Yep.
Elsie?
Elsie, which one do you think it is? D. I see in the chat. Awesome. That is correct. Question 3. What are the goals of infection prevention, control, and occupational health? So there's a lot of them. Is it education of healthcare workers and collaboration, provision of care and follow-up, along with identifying work-related infections? C, education of healthcare workers and collaborations with the department, along with regulatory compliance, or D, all the above? I am seeing some of the answers in the chat. D, yes, that's great. Awesome. Okay. Question 4, what level of the hierarchy of controls is most effective? So this was the graphic. So what was the most effective? Was it PPE, engineering controls, eliminating the controls, or substituting the controls? Awesome. Yes, C is the correct answer. All right, this should be an easy one. Establishing an exposure control plan is an OSHA requirement. True? False? Sometimes? Yes, A. It is a requirement. It's a regulatory requirement to have an OSHA bloodborne pathogen exposure plan implemented in your facility. 6. When a bloodborne exposure occurs, who determines what steps and protocols should be followed? Is it the individual who experiences the exposure, as in I have a sharp exposure, I get to decide what happens? Is it my supervisor, the person that's been exposed? Is it the bloodborne pathogen program administrator, or is it the infection preventionist? Yes, I saw C is correct. It's the program administrator, which is specifically documented and identified in your OSHA bloodborne pathogen plan. Question 7. What are the methods of implementation and control in the exposure plan? So there's a whole list of them. Is it isolation? Is it A, isolation, exposure to engineering controls? Is it B, universal precautions? C, universal precautions plus looking at soiled linen and labeling practices? Or is it D, universal precautions, exposure engineering controls, workplace practices, hazard disposal practices, including soiled linen and labeling? Yes, it's C. Thank you, Hannah. What is not included in the post-exposure evaluation follow-up? Who is responsible for the incidents, aka like causing blame or saying who's at fault? Looking at roots and exposures of how it occurred, who is providing medical treatment, and what medical treatment is needed. Yes, Alicia, it is a. During these events, we are never assigning blame to the situations. We're just trying to understand what has happened and identify our gaps in practices so that we can put in better prevention measures to ensure that this does not happen again. So this is never punitive, and don't ever feel if you do accidentally get exposed at work, this is not a punitive thing. We just want to make sure that you're safe, and if you need medical treatment, that we are aware that something has happened so that we can get you the treatment and the testing that you require as well. So don't ever be scared to report that you've had an incident. Question 9. Nurse Smith experiences a bloodborne pathogen exposure. They notify the bloodborne pathogen program administrator. They make the exposure determination. Nurse Smith receives treatment. Copies of the events of the evaluation go in where? Nurse Smith gets a copy, and a copy goes into their employee file, and they personally get a copy. Nurse Smith's employee file gets a copy, and it goes to their supervisor. Nurse Smith gets an employee file only, so it just goes into their employee file. She doesn't get a copy, or they don't get a copy. Or D, trick question, we don't have to record any of this. And I did see in the chat, yes, it is A. So during the event, the exposed individual will get a copy of the report along with what treatment, so that will serve as their record. And this is really important. So like if they decline treatment or testing, they have a copy, and the organization has a copy saying treatment was declined and that they were aware that treatment was declined. So that's why 2 copies are needed, and it's great for your personal records as well, to say like if something did happen at work or you need follow-up treatment or anything like that, having a copy at your disposal, and then your organization as a regulatory component having a copy in their file as well. So here's the last question. What is not a safe sharps practice? Filling sharp containers to the designated fill line, using standard precautions when handling sharps, recapping needles, using puncture-resistant trays to transport. And yes, Megan, the answer, that is correct. It is C, recapping needles. You don't ever want to recap a needle. That's the #1 way you're most likely to have a sharp exposure. So do not recap it. Directly put it in that sharps container. And so here's the answers. And for those that scan the QR code, if you hit submit, your grade will show up on your quiz to see how you've done. And then finally, we invite you all to connect with us. Our specific core email is here. If you have any questions, we're more than happy to answer them in email, or we'll open it up now for questions as well. But you can feel free to email us at ipc@tepi.texas.gov. The top QR code is to our educational series that we're doing this year. Along with the bottom QR code is just different resources on the TEPI page as well. And we invite you to connect with us on social media, on LinkedIn, on Facebook as well. And then lastly, we just want to thank you all for attending today's module. Here's that QR code to give that post-survey module feedback. We would really appreciate it if you can fill that out. We use that information to develop these modules, kind of give you the content that you are seeking. Our next module will be on April 4th over surveillance. And now we will open up to any questions that any of you will have. So feel free to just raise your hand again, and we will unmute you to answer your questions. We are still looking at CE credits. What specific credits are you looking for that kind of will help us through this process? Are you looking for IPUs for infection prevention? So last year's module I submitted to CBIC and they denied the IPUs. This year I'm working on resubmitting them as well. If they do get approved, we're more than happy to send those out for you, but currently they are not approved. But we are working on it to get CEs developed for this material. What's ABSA? Sarah, can you expand on your acronym, your ABSA? Okay. Okay. Any other questions? Question from Danielle. Are there any promising practices that ensure volunteers such as those of Medical Reserve Corps for having immunization or vaccination that are in high risk exposure? Are you talking about in healthcare settings, a specific endemic area? I mean, your vaccination requirement in a healthcare setting will be based on what specific area that you're in. So if you are in an endemic area, such for like yellow fever or more of those like tropical infections, if that's what you're looking for, that will be part of your risk assessment and your occupational health development plan. So the pre-vaccination immunization is based on your facility and most likely what your facility service line and the patients that you see. So that's how that gets developed. For your specific organization, you can always ask, especially when you're being onboarding, what vaccinations are required. Some facilities allow acceptance, some decline. It's up to the organization of how they want to implement it when it comes to vaccines. So it's really up to the facility level. With vaccine requirements, especially each state has different vaccine requirements, and then if there's OSHA and those kind of components, so it's very state and organization specific, long and short. So there's not one umbrella answer for that, Danielle. Yes, the email within a week should be sent out with a copy of today's recording and the slide deck as well.
But it shows on the.
Any other questions?
So you could tell them that we'll make sure to send out a link to this in the blog.
Yes, and we'll send out an additional link to the survey if you're unable to scan the QR code that's in the slide deck as well. Well, thank you all for attending today's module. We hope you enjoyed it, and we look forward to seeing you at future modules.